محاضرة عن الهايبرتنشن. so إحنا المرة الماضية حكينا عن the classes of الهايبرتنشن الدrugs اللي can be used بالهايبرتنشن، وبلشنا باللي first ينعطوا كفirst line including الكالسيوم channel inhibitors، الdiuretics، الرينين angiotensin system inhibitors مثل الARBs والACE inhibitors. We mentioned as well البيتا blockers. While beta blockers مش initial first treatment، بس حكينا many of these patients need combination therapy, and beta blocker is still used widely بالhypertension as an add-on therapy. Now we'll continue other classes, and the first other class اللي بنبلش فيه بهاي المحاضرة اللي هم alpha 1 adrenal receptors blockers. Now الألفا 1 blockers هم they are vasodilator. Okay, they مثل أي شيء ينتهي بالزوسين، so prazosin, doxazosin, terazosin. These are alpha 1 adrenal receptors blockers, and when if you remember من general physiology إنه blocking الألفا 1 can cause dilation، لأن stimulation of alpha 1 receptors بالvessels بيسوي عنا constriction. So they cause relaxation of arterial and venous smooth muscle، فيسوي عنا vasodilation، فيقلل resistance ويقلل blood pressure. However, alpha 1 adrenal receptors blockers can cause reflex tachycardia. Okay, and they also can cause orthostatic hypotension خصوصا as a first dose phenomena. So in these patients, if you decided to give them alpha 1 adrenal receptors blocker, maybe you need to start with smaller doses and increase the doses gradually, and also advise the patient إنه this may happen، الhypotension may happen، فلما يقعد ويقوم stand up slowly. Okay. Now they are not used as initial treatment. Okay, but they're used بالrefractory cases. إذا أنت البيشنت أنت معطيه الoptimal doses بالدrugs اللي حكينا عنهم قبل. Okay, the first line treatment, but they still ما عم بصير تحكم بالblood pressure, so you can give them as an add-on therapy alpha 1 blocker. The other class اللي هم we call them centrally acting adrenergic drugs. Now these centrally acting adrenergic drugs, they act as alpha 2 agonist. So previously we said alpha 1 antagonist. These are the alpha 2 agonist. And one thing you need remind yourself, what is alpha 2? Alpha 2 receptors, when they are stimulated, they're regulatory receptors. So when they are stimulated, they reduce the release of epinephrine, and reduce the release of norepinephrine, the main neurotransmitter بالsympathetic nervous system. And if they are stimulated by central nervous system, then you reduce a sympathetic outflow. And when you decrease the sympathetic outflow, you decrease peripheral resistance and blood pressure. The first one is clonidine, and it's an alpha 2 agonist. It's used primarily بالhypertension not responding to adequate treatment with one or two or more drugs. So they are alternative drugs. Again, للhypertension, you cannot, patient they're trying different regime, trying different combination, but the patient still ما reach the goal of hypertension, so you can try it with clonidine. الكلونidine it can be given للبيشنت اللي عندهم renal diseases، لأنه ما بيأثر لا على renal blood flow أو glomerular filtration. Okay, so still safe بالpatient اللي عندهم renal diseases. Now الكلونidine, it has يعني شوي ناستي أو يعني عندهم الكلونidine has a يعني difficult side effect including sedation, dry mouth, constipation. And also clonidine, if the patient for one reason or another need to يعني you want the patient to stop taking clonidine, you need to taper the dose or you need to stop it gradually. You cannot stop الكلونidine فجأة لأنه it causes an يعني a dangerous rebound hypertension. Okay, so and it's difficult to treat يعني it's بصير resistant حتى للتريتمنت فالكلونidine cannot be stopped abruptly. The other alpha 2 agonist اللي هو الميثيل دوبا. Okay, so it also works على central nervous system. It decreases sympathetic outflow. الميثيل دوبا المين side effect هو الsedation والdrowsiness and يعني given its side effects في البيشنتس يعني they have low adherence للميثيل دوبا, but also it's not because of that. Also الميثيل دوبا it has a short half-life and it needs to be taken multiple daily doses. So الميثيل دوبا is mainly used, it's safer يعتبر نسبيا safe بالpregnancy. For its main use is the management of pregnancy-induced hypertension. And this is one of the drugs that's first-line agent in hypertension and pregnancy. Okay, the third class of these other drugs اللي هم vasodilators. Okay, so they are direct acting smooth muscle relaxant and they primarily dilate the arterioles than the veins. These include hydralazine and minoxidil. Now these both vasodilators they are also again يعني useful بالrefractory hypertension. Hypertension is not responding to previous treatment. Okay. However, hydralazine is also used مثل الميثيل دوبا is also used بالpregnancy-induced hypertension or hypertension during pregnancy. Now, minoxidil can be used topically to induce hair growth. Okay. And used بالalopecia أو male pattern baldness as a topical agent. Now, side effect of these direct vasodilator include reflex tachycardia. Again لما أنت فجأة تسوي vasodilation الجسم the body respond to this lower blood pressure, sudden blood pressure إنه it increases the sympathetic flow, it increases the cardiac output by increasing the heartbeat. This is what causes the reflex tachycardia. And in this situation, it can prompt angina and myocardial infarction. Okay. Now, the other thing, they increase the plasma renin. These vasodilating can increase the plasma renin, and so they increase the sodium and water retention. One way to lower these side effects اللي هو يعني slowly introduce doses, escalated dose slowly. So فمثلا بالرeflex it will help مثلا بالreflex tachycardia بالhypotension. Also use a diuretic to reduce the sodium and water retention. And also you can give beta blocker حتى كمان تقلل من reflex tachycardia. Other side effects include the headache, nausea, the sweating. It can precipitate arrhythmias and angina. One common side effect اللي هو lupus-like syndrome. lupus syndrome اللي هو البيشنت بصير عنده fever, بصير عنده fever, بصير عنده muscle pain, بصير عنده joint pain. فإتس مثل الانفlammatory disease. However, in this situation, it's a drug-induced lupus syndrome. If you stop the medication, the symptoms will disappear. Okay. Um, again, this is one of يعني شوي common side effect للهيدرالازين والمينوكسيديل. Okay. We said the blood pressure is not responding to other treatment. It has a medical يعني term اللي هو مسميه احنا resistant hypertension. what is the resistant hypertension؟ شو تعريفه بالضبط؟ It is اللي هو blood pressure remains above the goal, the blood pressure goal, even though you're giving الoptimal dose أو optimal regime of at least three drugs from three different classes. And again, remember first line treatment اللي هم ACE inhibitor, ARBs inhibitor, calcium channel اللي هم dihydropyridine, calcium channel blockers with thiazide-like diuretics. Now, the causes of resistant hypertension. إذا البيشنت أجاك وأنت شفت إنه أوكي البيشنت على combination therapy, you need أول شيء to make sure إنه الcombination صحيحة، الدوز صحيحة، الcombination صحيحة. for example إذا البيشنت مثلا جايك إنه والله الcombination تبعته include ACE inhibitor or ARBs inhibitor, then this is the reason why it's not working, because these two are working the same system, the renin system. So probably you make sure it's not about the combination, it's not about the insufficient dose, okay? Now, also you need to make sure the patient is compliant. Is the patient taking medication in the right time, يعني right doses? Okay, the patient is also helping himself or herself they يعني إنه ما ياخذ كثير مثلا sodium intake أو they're not consuming a lot of alcohol, ethanol intake. Now also the other thing that can يعني make it difficult to maintain a good blood pressure اللي هو وجود other diseases مثل diabetes, obesity, sleep apnea. فإذا البيشنت عنده هاي الأمراض, it probably will make it difficult to control their blood pressure, as well as other medication مثل السمباثوميميتيك والنون-steroidal anti-inflammatory أو الكورتيكوستيرويد. كلها كمان they induce يعني أو they antagonize many of these antihypertensive drugs that make it difficult إنه يعني reach the goal blood pressure, and this is what we call a resistant hypertension. Now, the other thing we need to talk about are the hypertensive emergency. Now, the hypertensive emergency اللي هو إنه البيشنت comes with acute elevated blood pressure. The main thing is you need to have a sign of organ اللي هو target organ damage. Okay, so to diagnose a hypertensive emergency, you have sign of organ damage, and you have a high blood pressure. Now, this hypertensive emergency could happen either in patient with the previous hypertension history or يعني without known pre-existent hypertension history. Now, we need also to make يعني نميز بين hypertensive emergency, okay, and what's previously was called hypertensive urgency. Okay, hypertensive urgency now it's called severe asymptomatic hypertension. The patient بيجي بسevere severe high blood pressure اللي هو اللي أكثر من 180 على أو أكثر من 120 blood pressure, and بس نسبيا ما في symptoms, ما في sign لل end organ damage. This what we call severe asymptomatic hypertension, which previously was called hypertensive urgency. Now, it's not those patients. Most of these patients could be used as an outpatient with their regime. ممكن تزيد الرجيم، ممكن إنك make sure they're taking their drugs يعني appropriate in appropriate way and appropriate dosage, and it does not mean إنه إذا ال blood pressure 180 على 120 يعني it's need an hospital administration. إذا كان عندنا مثلا high blood pressure أكثر من 180 على 120 with a sign of end organ damage, then this is an emergency. The patient لازم يكون يعني يتعامل as an inpatient, and this is what we call hypertensive emergency. Now الhypertensive emergency حكينا إنه high blood pressure with end organ damage, and the end organ damage, this what makes the hypertensive emergency. There are different scenarios. So for example, we have hypertensive encephalopathy اللي هو بصير عندنا edema بالبرين، فبصير عندنا ضغط على البرين. The patient may come with headache, visual disturbances, confusion, seizures, and even coma. أو إنه يأثر على الريتنا of the eye. كمان نفس الإشي يصير increase intraocular pressure، فيصير leakage بالeye blood pressure, and it may cause يعني sudden visual disturbances and even sudden يعني blindness, and this is what we call hypertensive retinopathy. أو مثلا يصير عنده hypertensive cardiomyopathy، مثلا يصير عنده signs of myocardial infarction, unstable angina, heart failure with pulmonary edema. أو إنه يأثر على الكدنيز، يصير عنده نفروباثي، يصير عندنا bleeding أو microscopic hematuria اللي هو blood باليورين، أو elevated creatinine، أو إنه يصير عندنا hemorrhage intracerebral بالدماغ، يعني intracerebral hemorrhage مثل. فيجي البيشنت with يعني neurological signs وكوما، أو إنه الأيورتيك dissection. البيشنت اللي معهم aortic dissection one of the sign اللي بصير عندهم acute severe back pain، اللي هو إنه بصير عندنا laceration بالaortic بالaortic artery بالaorta، two layers of the aorta يصير لهم separation. Okay, and aortic dissection may also develop ويصير rupture. It's again you need to deal with this emergency. In the pregnant patient, it's pregnant patient ممكن يصير عندهم seizures اللي هو what we call eclampsia and even coma. So the treatment of hypertensive emergency تعتمد على specific hypertensive emergency. Okay, so حكينا إحنا we have different scenarios which organ what's really happened بالpatient، تعتمد بشكل كبير على ال end organ damage. بس بشكل عام you want to avoid the sudden drop blood pressure، لأنه الجسم يعني لفترة طويلة كان it has this high blood pressure, so it accommodates, it auto-regulate itself إنه keeps the perfusion للorgans at this level of high blood pressure. So when you suddenly drop blood pressure بشكل كبير، الجسم cannot accommodate for this, and it will really reduce الperfusion blood perfusion للorgan, especially مثلا الدماغ يعني مثلا. blood pressure arterial blood pressure need to be ولو إنها هي عندهم really high blood pressure, however you need to شوي gradually reduce blood pressure. فمش أكثر من 20 إلى 25% within the first hour. This gets you probably a blood pressure lower than 180 على 120. Then the next 24 hours, 23 hours, you need to reduce الجول تبعك reduction of blood pressure between 5 إلى 15%. And within the 2 next days, you يعني stabilize the blood pressure للtarget blood pressure للpatient. Now, this is in most cases. However, بالaortic dissection احنا بنخاف انه يصير عندنا increase الشيرنج forces وincrease اذا كان عندنا high blood pressure بالايورتا ممكن يزيد الشيرنج force، ممكن يصير عندنا rupture. فin this case you want a more rapid reduction بال blood pressure. Now these يعني عشان تشوفوا الفرق إنه كيف التعامل بالemergencies. فمثلا I have 2 examples. مثلا hypertensive emergency with the patient مثلا with acute left ventricular dysfunction with pulmonary edema. So البيشنت عنده acute left heart failure. اوكي وصار عنده congestion يعني بالرئة، فعنده pulmonary edema. So الجول تبعك بالتريتمنت انه you want to reduce the volume access and improve the cardiac output وimprove pulmonary edema حتى البيشنت يقدر يتنفس صحيح مرة ثانية. So drugs used أول إشي you give loop diuretics. اللوب diuretics هسا إحنا حكينا الثيازايد هم اللي بيستخدموا first treatment option بالhypertension على إنه long term. أوكي بس لما يصير عندنا إحنا acute left ventricular heart failure أو حتى عندنا heart failure الفيروزما اللوب diuretic they are a higher ceiling diuretics، فالdiuretics تبعتهم أقوى. and these loop diuretics مثل furosemide مثلا IV can be given in this situation. nitroglycerin حكينا إحنا it's vasodilation خصوصا للفين. فأنت لما تسوي venodilation بتقلل البريلود، you pull down the blood وتقلل congestion إنك you pull down the blood من pulmonary arteries more of the venous side, as well as with higher doses nitroglycerin given in higher doses with this situation it may also cause arteries to dilate. فحتى artery can dilate فبتقلل afterload, and by this you reduce the pressure, you reduce the workload على الهارت، تعطي فرصة للقلب إنه function يعني يحسن من functions of the heart. You need to avoid الهيدرولازين اللي هو it's a direct vasodilator لأنه it causes reflex tachycardia, and when it causes this tachycardia can increase the cardiac workload and يعني شوي يسوي الأمور أسوأ. البيتا بلوكر as well بالأكيوت. والبيتا blockers can reduce the mortality بالpatient اللي عندهم ventricular heart failure خصوصا reduce ejection heart failure. However بالأكيوت decompensated phase you need to avoid the beta blocker لأنه الpatient عنده بالأصل decrease cardiac output. So if you give a beta blocker you are depressing the heart, depressing the cardiac output بزيادة، فيصير عندنا يعني severe hypotension. The other thing إنه هو يجيك البيشنت بهاي blood pressure مع acute coronary syndrome، مثلا يجيك مع myocardial infarction. Again هون الجول to reduce the myocardial oxygen consumption reduce the coronary ischemia وimprove حتى improve the prognosis. The drugs used اللي هم nitroglycerin again they reduce the preload والafterload for reduce the myocardial oxygen consumption. ال IV calcium channel blockers خصوصا dihydropyridine. Now إحنا حكينا المثال عليهم اللي هم الالترا شورت acting dihydropyridine مثل الكليفيتيبين والنيكارتيبين. Now إحنا حكينا إنه الشورت acting cardio calcium channel blocker should be avoided بالpatient اللي عندهم hypertension لأنهم predisposed للmyocardial infarction. Okay, but this is what these are the immediate, the oral one, the one that is بسموهم immediate release. Okay, بس هون بهاي بالmyocardial infarction you can give these ultra short acting. Now these ultra short acting dihydropyridine, they will cause vasodilation. اوكي بس الريفلكس تاكيكارديا تبعتهم بيكون less than الشورت اكتنج او الاورال شورت اكتنج dihydropyridine calcium channel blockers because they have this هم fast onset و short acting. This is what we call إنه drug they can be titrated. شو يعني؟ أنت بالinfusion you can control يعني أنت لما تعطي أنت بالinfusion وتتحكم بالinfusion rate تقدر تتحكم بالدوز. فأنت شوي بتبلش فأنت بتشوف any signs of مثلا رح يصير والله عندنا tachycardia you can stop التريتمنت فجأة يعني بسرعة أو تقلل الريت فكان you can control how much the blood pressure is as reduction of blood pressure you can control إذا symptom مثلا إذا side effect معين أنت you want to avoid you can control it and you can prevent it بسرعة because بسرعة الeffect تبعهم wear off إذا أنت stopped the treatment because they are short acting. Okay, and they do not accumulate بالtissue you have a really good control على الدوز على الeffect تبعهم how much they reduce the blood pressure how much إذا صار مثلا side effect بدايات side effect أنت when you monitor the patient and مثلا بدايات tachycardia you can stop it to prevent it بسرعة. But this is what we call titration of the drug. Within these 24 hours, 48 hours, you need to start beta blocker مثل الميتابرولول والإزمولول وحكينا البيتا blocker in this situation they decrease the mortality of the patient وimprove the prognosis. Okay, okay, هاي بس إنه this is the these are the drug classes ومثلا إذا عندك disease what can you give what you cannot give يعني أو شو ال preferred drug class. مثلا عندنا stable ischemic heart disease beta blocker حكينا increase survival الACE والARBs inhibitor they also can they're cardioprotective also can improve survival. Calcium channel blockers can be also given in this patient ما في contraindication بالموضوع. إذا عندك يعني hypertensive patient with diabetes you can still give diuretics even though there is a chance إنه يسوي hyperglycemia but you can still give diuretics maybe reduce the dose of diuretics maybe increase the dose مثلا of insulin عشان تتحكم يعني بالhyperglycemia but the patient can still benefit from diuretics. البيتا blockers if you can avoid البيتا blocker it's better لأنه حكينا البيتا blocker they can mimic الhypoglycemia symptoms. الACE والARBs والكالسيوم الACE inhibitor والARBs inhibitor they are can be protective خصوصا إذا البيشنت عنده diabetes complicated with nephropathy. فالACE والARBs can help with the albuminuria. الكالسيوم channel blockers يعني they are good control the hypertension and they do not يعني mess with the glycemia profile. Okay, they don't have metabolic effect you can safely give them to diabetic patient. A patient with recurrent stroke, again, you can give diuretics, ACE inhibitor, ARBs. These are the first line treatment. الهارت failure الهارت failure many of the patients are on diuretics خصوصا اللوب diuretics. بالبيتا blockers they can increase the survival in heart failure with reduced ejection fraction. ACE will ARBs as well, they have this cardioprotective and because the patients, many of these patients can يعني على diuretics for a long time. الالدوستيرون receptor antagonist اللي هم الابليرونين اللي هم البوتاسيوم sparing diuretics مثل الابليرونين you can still give the patient can benefit from these potassium sparing and their diuretic effect بالheart failure. Previous myocardial infarction, again, beta blockers can increase the survival. ACE والARBs again الالدوستيرون receptor antagonist خصوصا السبيرونولاكتين الابليرونين السبيرونولاكتين حكينا they may also يعني reduce the remodeling those situation, remodeling of the heart cells in this situation. بالchronic kidney disease الARBs اللي هم الرينين angiotensin inhibitor اللي هم الACE inhibitor الARB inhibitor they are renoprotective and you can give them يعني they will have this extra benefit بالchronic kidney disease. Okay, now إحنا خلصنا باقي المحاضرة هي عبارة عن أسئلة. If you want to pause يعني وأنا أشرح it's up to you. So the first question اللي هو 59-year-old non-Hispanic white man present for management of hypertension. His medical history include diabetes, hyperlipidemia with no chronic kidney or heart failure. His blood pressure reading at 2 consecutive visits are 159 على 96, so he is stage 2 hypertension. Which of the following is the most appropriate initial hypertensive therapy? So again, this patient, okay, could benefit from the initial combination therapy. And when you think of initial combination therapy, okay, you think of diuretics, you think of calcium channel inhibitor, dihydropyridine calcium channel inhibitor, you think of the renin-angiotensin system inhibitor. Okay, فيو think of these two combination. فمثلا enalpril البريل هو الACE inhibitor. So an ACE inhibitor with amlodipine. الاملودايبين اللي هو dihydropyridine calcium channel blocker. So okay, يعني probably this is a good choice. Okay, let's see the other choices. Enalapril, metoprolol. Metoprolol is a cardioselective beta blocker. It's not a first choice. Especially إنه ما عنده مثلا heart failure, ما عنده patient history of myocardial infarction, there's no extra benefit للbeta blocker in this situation, so it's not the most appropriate initial antihypertensive therapy. الverapamil losartan. الverapamil اللي هو it is a calcium channel blockers, but it's the non-dihydropyridine, the one that affect both the heart and vessels. And the non-dihydropyridine calcium channel blockers, they are not the first choice. First choice اللي هم الدihydropyridine. losartan اللي هم ARB blockers, angiotensin 2 blocker, which is okay, right? You can start with them, but not with the non-dihydropyridine. So C, it's not a good choice. Enalapril again an ACE inhibitor with losartan اللي هو حكينا angiotensin 2 blockers. Now you cannot give an RAS inhibitor, okay, يعني combination. So you can't give an ACE inhibitor مع ARB inhibitor. Because you predispose the patient to severe angiotensin system inhibition, you can predispose them to severe bradycardia, hypertension, severe 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 hyperkalemia. You cannot give these two together. Okay. Again, الفيراباميل مع الميتوبرولول it's a non-dihydropyridine مع beta blocker. Neither of this are a first choice or first line treatment in this patient. So A is the most appropriate treatment. ACE inhibitor مع dihydropyridine calcium channel inhibitor. السؤال الثاني, a 48-year-old woman presented to the clinic for evaluation of newly diagnosed hypertension. Her blood pressure in two separate visits is 148 على 92. Again, stage 2 hypertension. Her medical history is significant for moderate persistent asthma. Treated with inhaled corticosteroid, short-acting beta-2 agonist. Okay. She has no history of diabetes, kidney disease, or cardiovascular disease. Which of the following is antihypertensive medication would most appropriate for the patient? You have propranolol, metoprolol, hydrolazine, and amlodipine. So propranolol, metoprolol are both, propranolol is non-selective beta blocker, and in this situation it's absolutely contraindicated لأن البيشنت عندها asthma. Okay, so it's non-selective beta blocker, absolutely contraindicated بالasthma. Metoprolol, it's a cardioselective. You still need to avoid in patient with asthma. Okay, and again, in this situation, there is no benefit of a beta blocker. Okay, so and beta blocker are not the first line treatment بالhypertension. الهيدرولازين is only conserved للpatient اللي عندهم resistant hypertension أو الhypertension بالpregnancy. Now الأملودايبين حكينا اللي هم dihydropyridine calcium channel blockers, which are a first line treatment, and so is D is the most appropriate treatment for this patient. Okay, هاي بسرعة, which of the following is considered a first line antihypertensive drug class بالgeneral population? In alpha blockers, not. Central alpha 2 agonist, again, both of these are للpatient اللي their blood pressure is not يعني controlled with first line treatment. Beta blockers, no, they're not a first line treatment بالgeneral situation ولا direct vasodilators, so it is the thiazide diuretics. Okay. A 54-year-old woman with severe essential hypertension refractory to treatment. So you're given the right dose, you're given the right combination, but still you cannot get a patient to its to her blood pressure goal. So she was given a new antihypertensive drug 1 month ago. It could regulate her blood pressure, but now complain of excessive hair growth. Which antihypertensive drug is she taking? So this new drug, which is probably given لأنه هي عندها يعني uncontrolled hypertension with the right combination of first line treatment, but again, and this drug causes excessive hair growth. Okay. So which one of them? It's the minoxidil. It's the one of the vasodilator. It's a known side effect of minoxidil, and actually a topical minoxidil is used to treat alopecia. Okay, a 52-year-old female has uncontrolled hypertension, stage 2 hypertension on treatment with lisinopril. She is on ACE inhibitor. She recently had a myocardial infarction, and her past history include diabetes, hypertension, hyperlipidemia, and osteoarthritis. Consider her compelling indication which agent may be appropriate to add to her antihypertensive therapy. So again, she has uncontrolled hypertension. She need a combination therapy. Lisinopril is not enough. She had a significant piece of information here is she had a myocardial infarction. And when you hear a myocardial infarction, you need to think of which drug class can improve the prognosis and reduce the mortality in these patients. Okay, now you need to be careful. She has diabetes, she has, as well as the hypertension, she has hyperlipidemia, and as well as osteoarthritis. Now, the first choice they're giving us is clonidine. Clonidine is has a يعني it's not a first choice in this situation. It's not a first choice. You think you يعني بعد ما البيشنت يكون على combination therapy and still not well-controlled blood pressure, you think of clonidine. Clonidine does not have any protective بالمyocardial infarction, ما في له protective role. Olmesartan is sartan. Okay, sartan is an ARB inhibitor. It is one of the classes that are indicated as a first-line treatment with hypertension. But remember, she is already on lisinopril. She is already on an ACE inhibitor. You cannot combine an ACE with an ARB. الفيورزمايد يعني عادة إحنا نفكر الثيازايد diuretics بالhypertension, not the furosemide, unless there is يعني chronic reduced kidney function. So, and furosemide in this case, it has not يعني هون a compelling indication, يعني does not have any protective خلينا نحكي role in this situation. Metoprolol, it's a selective beta 2 antagonist, and as we said, beta 2 blockers, they can decrease in mortality with myocardial infarction. So from these four choices, metoprolol is the most compelling drug to add to lisinopril حتى يعني control her hypertension حتى increase the survival لأنه عندها myocardial infarction. Now, in this situation, this particular situation, you want to give a patient a selective and avoid a non-selective لأنه حكينا non-selective مثل propranolol, they are more associated with increased triglyceride and reduced HDL. And she already have this hyperlipidemia. Okay. Now, metoprolol is not يعني something you give ideally بالdiabetes, but in this case, so this case is not super straightforward. This case, the patient still benefits from the cardioprotective properties of the beta blockers because she had a myocardial infarction. Now, with her diabetes, you need to make sure the patient knows that there is probably يعني she will be less hypoglycemic aware, and but still, even though she has diabetes, still you can give metoprolol, can give a beta blocker because of her myocardial infarction. 58-year-old African American with hypertension managed with nifedipine, a dihydropyridine calcium channel blocker, present to his primary care physician for follow-up. His blood pressure is 136 على 84. Physical examination of the heart, lungs, and abdomen are within normal. The most likely effect of this medication to cause blood pressure reduction likely involved. So here, this question is asking about the mechanism of nifedipine. Okay, so mechanism of the calcium channel blockers and reducing blood pressure. So it's these blockers will affect will affect vessels. They cause mainly vasodilation, especially بالarteries. They have little to no effect على veins. So here you're thinking of some mechanism على vasodilation, especially بالarteries. The A increased venous capacitance, while they can cause vasodilation, but it's mainly targeted to arterial rather than veins. So A is one. Decreased arterial smooth muscle contraction. When you decrease arterial smooth muscle contraction, you decrease the peripheral resistance, you decrease the blood pressure. And actually, this is how these nifedipine works. Okay. Nifedipine does not work on heart, so reduce cardiac automaticity, increased myocardial contractility, and even يعني أولا النفedipine does not work on the heart, and the calcium channel blockers anyways they decrease the calcium influx, they decrease the contractility. They do not activate the alpha 1 receptor, even though and actually activating alpha 1 receptor causes vasoconstriction. So this is يعني kind of an easy question. بس you need to know إنه النفedipine أو dihydropyridine calcium channel blockers, they mainly work على decreased arterial resistance أو vasodilation بالarteries rather than veins. Okay, آخر سؤال اللي هو 54-year-old man with diabetes present to clinic for a routine checkup at so he has diabetes. Prior to visit, he had an elevated blood pressure and has tried lifestyle changes to improve it. Today, his blood pressure is still 142 على 88. His last urine analysis showed a urine microalbumin of 150 MCG. What is the most appropriate initial antihypertensive for this patient? So this is a diabetic patient, and now you are sure he has يعني 3 visits showing 3 بالoffice. he took blood pressure تبعه بالoffice and in 3 different visits and still has elevated blood pressure. So you need to initiate a treatment for his hypertension. And remember, he is diabetic, and not only diabetic, he is starting to show signs of nephropathy, signs of kidney disease related to his diabetes, which is increased the albumin in the urine. Okay. So when you think of an initial therapy, you need to think of the first line treatment classes that can also improve his nephropathy. So which drug is it? Is it doxazosine? It's an alpha 1 receptors blockers. They are not even used as a first line treatment. So no. Hydrochlorothiazide, they are first line treatment. But in this patient, they do not have any benefit على his microalbuminuria. الميتوprolol is not a first line therapy. It's ما في أي indication إنه تفيده. Because of his diabetes, you probably want to avoid beta blocker. Nifedipine as well, well, it's a first line treatment choice, but in this patient ما في أي effect يعني ما في أي protection extra benefit for his nephropathy. The only choice, the most appropriate choice اللي هو ACE inhibitor, lisinopril. Okay, lisinopril is an ACE inhibitor, and as we said before, they have they are renoprotective, and they can reduce improve renal function بالnephropathy and reduce الalbumin in the urine. اوكي خلصت المحاضرة. إذا أي حدا عنده أي سؤال ابعثوا لي على التيمز. I will stop recording now.